Good morning, everyone. As I was kindly introduced, my name's Hatim. I'm a GP in a practice in North West London and spent most of my week now leading the Health Innovation Network in Kent, Surrey, Sussex. I want to talk to you about some work that I was involved with preliminary when I was working nationally for NHS England, particularly as part of the long-term workforce plan, of course, big topic today, and the use of artificial intelligence. But before I do that, I want to talk to you a little bit about the work that we are doing at Health Innovation Kent, Surrey, Sussex. We have formed the digital data and AI portfolio, and for us it's important to support our three integrated health and care systems in our locality on three key issues. The first is digital and data transformation, examples there being our work with the secure data environment and the Sussex integrated data set. We are helping to use data to transform the way we do health and care for the future, working with our systems. The second is workforce capability and capacity building, and this is building on some of the work within the long-term workforce plan to try and make sure that we have a workforce for the future that is able to utilise the technologies that we're talking about and have the right skills to change the way it works. Because I think a key part of this is not just capability, but capacity. So do these technologies truly release time? Are they going to achieve the productivity targets that we have set ourselves? And then finally, lots of policy work, lots of strategy work helps point us in the right direction. We've, just sitting there today, we've heard about the major condition strategy, for example. That's all well and good, but being a GP, I've seen the disconnect between the work that's done nationally and then the work that happens on the ground. And therefore, it's important that we support our local health and care systems to be able to turn that policy and strategy into action, bringing some of those skills and learning around change management, around digesting what these strategies mean, to then how does that work in terms of commissioning to create the change you want to see. And we're doing some work with Surrey Heartlands in particular on that journey on artificial intelligence. So then why artificial intelligence? Well, the first thing to say is we need new tools. When I'm sitting there in my clinic room, there is no doubt that I need new tools to make myself more efficient and make my job more enjoyable. There's an exponential rise in medical knowledge. So we know now that every 60 days, medical knowledge in literature is doubling. How do we ever keep up with that level of increase in medical knowledge? We know that from the BMJ, that it takes about 17 years for something that is proven to have evidence to be widely adopted in practice. Can we narrow that gap? And we want intelligence. We want intelligence due to all the data that's sitting out there in our systems, in our electronic healthcare records, the data that people hold themselves. The data exists in society around shopping data, for example, crime data. All of these help us to understand wider determinants of health and then make decisions based upon them. When I'm sitting in my clinic room on a Friday, I'm balancing a number of tasks. I'm not only seeing my patients in front of me that are on my list, but I'm doing prescriptions. I am also doing and dealing with letters. I might have a call from London Ambulance Service to get advice about a certain patient. The nurse will knock on my door. I'm juggling a number of these tasks while also trying to figure out if I'll get home in time to see my family. Also make sure I pick up the shopping on the way home. I'm trying to think about all of these things. And the reality is the more we automate those basic tasks that don't require my intelligence and other members of my staff in my practice and more widely, then we won't make our jobs easier and we won't deal with the pressures that we see in the NHS. And finally, we can use this technology to improve medical education and training. I worked in education and training for a long period of time now, and there is no doubt that we can use technology to, one, train our future doctors, future nurses, future physios and so on better and quicker and more effectively if we utilise things like artificial intelligence, but also in conjunction with immersive technologies and so on. So we want to achieve precision medicine. In 2019, I was part of the Topol. I didn't work on the Topol review, but I worked on the outputs of the Topol review. But I remember talking to Eric Topol, and Eric Topol, who was a professor at the Scripps Institute in the US, was asked to come to the NHS and help us think about how we're going to have a workforce for the future. In 20, 25 years' time, what do we want to achieve? And he painted his vision for a health and care service which is rationalised and tailored to the individual. And for me, that vision was hardware hitting. That's exactly what we want to achieve, precision medicine. But to get that, there's a gap. There's a gap between what we see in evidence and there's a gap between what we get in real-world evidence or real-world intelligence. And bringing that together will help us achieve precision medicine. Artificial intelligence. Many people, it's a term which instills a little bit of worry or fear. For me, it's bringing it back down to what exactly is it as a technology? What does it do? The Topol Review defined AI as a broad field of science, encompassing computer science, psychology, linguistics, philosophy. To bring all of that together to allow computers or use computing power to do tasks that would normally require human intelligence. That wider definition of AI is really important because it shows you how complex it is. It shows you how it's bringing a number of domains together. This is not just statistics or mathematics, although that's a big part of it. It is how that intersects with our lives and our conversations, our thinking, our beliefs. And that allows it to have a lot of power, but used in the right way, it can be very effective. And so within that, you have machine learning and deep learning. Machine learning is the ability for the computer to learn from the data at scale and to do complex tasks, but usually within a set of rules. And then you move into deep learning where it starts to be able to do things without necessarily the same oversight, and it starts to form new connections, new neurons in the same way that our brains do to generate new ideas. And I would put generative AI or large language models in that kind of deep learning box, even though there's questions about how exactly it works, because it generates new things, it generates new ideas. So where is the NHS with AI? The first thing to say is the NHS is heavily invested in this technology. And that's really important to note, because when I speak in other parts of the world, they're quite proud of what we've done in the NHS. They use our NHS as an example of somewhere that we are adopting this quite early, and sometimes we should be proud of the work that we're doing in the NHS. There's lots of narrative around the difficulties that we face as a health and care system, but the reality is we do lots of good stuff. In 2022, we published the AI roadmap and a dashboard that's associated with it. And this report associated the landscape of current AI and data-driven technologies in the NHS, but it broke it down into what exactly are they, what's their spread and adoption, and what's the workforce impact of these technologies. And we did that work over a period of time, so we started to do it and analyze some of the databases out there. We then developed a specific database to allow us to deep dive into some of these issues, and then we built the dashboard and some case studies. And effectively what we found was that 34%, and this is bear in mind 2 years ago now, 34% of AI and data-driven technologies were in diagnostics, 29% were in automation and service efficiency, and then a number were in P4 medicine and remote monitoring and therapeutics. I think it's quite interesting. One, it shows us where we are right now. Where can we utilize this technology right away? If we think about the concept of waiting lists, well, there are a number of diagnostic technologies out there that can help speed up waiting lists, because one of the bottlenecks is diagnostics. And not just the diagnostic itself, but the connection between the diagnostic and relaying that information back to a clinician. And that's where the automation and service efficiency is, because essentially you've got technologies that can speed up administrative processes, speed up the processes between MDTs and cancer, for example, or speed up processes in GP surgeries, like registrations, or looking at normal blood results, those sorts of kind of automation service efficiency tasks that I would describe. And then we move into the world where this technology will start to move into population-based medicine, so preventative, personalized, predictive, and participatory type technologies that allow to treat people in their communities at home and keep these people well in those communities, aligned with remote monitoring that still provides a level of safety and security for a healthcare professional to be able to keep an eye on that person somewhere else, but with the support of AI and data. And what we found also was that by 80% of the technologies that we found, and we found 240 technologies at the time, would be in large-scale deployment within 5 years. So this was in 2022. Again, we're not far away from this being a core part of what we do. We then also looked at the workforce groups, and I want to be very clear here, this is not about where we don't need workforce, but this is about which parts of our workforce are going to be working differently with this technology. Therefore, what skills do our radiologists need to have, or how might they be working differently as a result of using this technology? And actually, there's a really wonderful podcast from the RSM Digital Health section with Dr. Kath Halliday, who's the president of the Royal College of Radiologists, and she is brilliant on this. She says she doesn't want to be sitting there looking at X-ray reports or reporting X-rays all day. That's not her working at the top of her license. She wants to be involved in applying the context of what's in that X-ray report, working with MDTs, clinicians, to be able to make decisions for patient care. So it is rethinking what some of our workforce do. And same way in general practice, yes, it says medic in general practice, that's the way the kind of workforce codes work. But what about that wider workforce within general practice? How will it change the way we all work to move towards better care? A big factor to adopting AI is confidence in AI. If we're not confident in this technology, we're not going to be able to use it so well. And we kind of went on a journey from trust to confidence because we feel confidence is not binary. And the reason I say that is because with something like artificial intelligence, it's not binary either. It's in the context of what you're trying to use it for. And what you're trying to essentially get to, in the same way with any sort of clinical reasoning or reasoning of any technology, is an appropriate level of confidence. If you're too confident in this technology, then the reality is that you're not going to be making safe decisions and you're going to be over-relying on it. If you're underconfident in this technology, you're just not going to use it. And again, you're not going to be making safe decisions. So it's trying to find that appropriate level of confidence. And to do that, there are a number of factors. We need to have the right regulation. We need to have the right validation of these technologies. We need to hope that our bodies that we trust so much, MHRA, NICE, CQC, are able to report and analyze these technologies and make sure they're safe to use. At implementation level, we need to have the right strategy, the right culture, and open to adopting this technology. And then finally, using it clinically in my room, I need to understand what its strengths and limitations are. I don't need to be an expert in it, but I do need to know how it's going to help me with my decision making. I do need to know how it's going to affect my natural biases and add to those biases in using this technology, and therefore what I should do about that. And I need to find it easy to use, because there's no point in me having a technology that's hard to use and I'm going to make my job harder. My job's already quite hard on a Friday when I'm in clinic room. So let's try and find technologies that reduce that friction and make our jobs easier. So what about artificial intelligence in the NHS long-term workforce plan? I'm going to caveat this with the fact that I don't work for NHS England anymore and don't work on the long-term workforce plan. And of course it is, being refreshed as was planned when it was published. But this gives you a sense of direction to some of the recommendations we made at the time. And at the time we did some modelling. So we found that, firstly, then, as I said, we've invested in AI. So the NHS AI Lab is the world's largest programme on evaluation of healthcare AI products. And at that time, had 86 projects in 444 live settings, 99 hospitals and 344 GP surgeries. And we're seeing positive results in the use of artificial intelligence in lung cancer screening. We've seen positive results in the management of stroke. And we're seeing positive results in areas like dermatology pathways. So to take full advantage, a number of recommendations were made. Again, the timelines may not be up to date, but the commitments are clear. So to convene an expert group on AI to be able to understand where AI can be used and will have the most effect and positive effect. Review the initial evaluations from those examples. Support the government's AI task force, which is looking at generative AI, which I will caveat and say this technology is a lot further away from being implemented when it comes to generative AI. Classical AI is much more likely to be adopted right away. Building the workforce confidence, as I described, so implementing on those recommendations within that report. Implementing a capability framework, so we published a capability framework with the University of Manchester, which outlines what healthcare staff need to know about artificial intelligence, and then invest in programs like the fellowships in clinical artificial intelligence, which allows people to do AI deployment in the NHS, to be able to understand the language of how you get across some of the barriers like strategy, culture, working with industry, what evidence do you need, doing it safely and auditing. All of those sorts of skills are really important, and having clinical leaders embed themselves into that environment is also important. And that's me. So thank you for listening, and look forward to any questions later.